Hello everyone, and welcome to the Academy for Eating Disorders webinar entitled CBTe for Adolescents with Riccardo Dalle. My name is Rebecca Murphy and I am your moderator today. Also with us is Ronald Fan, AED's membership manager. If you have any questions or concerns about this webinar, please feel free to reach out to Dawn Gannon at AED headquarters via email at dgannon@aedweb.org. Just a couple of housekeeping matters before we get started. All participants are muted with the exception of the speaker and myself. The webinar is scheduled for 60 minutes and is being recorded. It will be posted on the AED website shortly thereafter for AED members to download at their convenience 24 hours a day. In just a few minutes, Riccardo will begin the presentation, after which he will answer questions from the audience. Please feel free to submit your questions to the speaker during the presentation using the Q&A text box on your screen, and I will read them to the speaker when the question portion of the webinar begins. Riccardo, let's check your volume quickly. Please just say a few words, and if a couple of participants could please let me know if you can hear him directly by sending a message in the Q&A box I just mentioned.
Good morning, Rebecca, and to all the participants. I'm very happy today to give this webinar on CBTe for adolescents.
Great. Thank you very much, Riccardo, and thank you everyone for letting us know your volume level is good. I'm Rebecca Murphy. I'm a clinical psychologist and researcher. I currently direct the Centre for Research on Eating Disorders at the University of Oxford. I delivered CBTe as a trial therapist for several years at Credo under the supervision of Christopher Fairbairn and Zafar Cooper. More recently, the focus of my work has been on disseminating CBTe. It gives me great pleasure to introduce our speaker today, Riccardo Dalle. And Riccardo started working at the Villa Garda Hospital in Italy back in 1985. And since 1992, he's been head of the Department of Eating and Weight Disorders. In this department, in collaboration with Professor Christopher Fairbairn, he's been responsible for two major developments in enhanced cognitive behavior therapy, or CBTe, for eating disorders. The first of these was to create a CBTe inpatient treatment, and the second, which he'll be talking about today, was to adapt outpatient CBTe for use with adolescents. Currently, the main focus of his research is evaluating CBTe for the treatment of adults and adolescent patients with eating disorders who are significantly underweight, both in outpatient and inpatient settings. He also teaches CBTe at several Italian psychotherapy schools and supervises CBTe teams in Europe, the US, Australia, and the Middle East. Please go ahead with your presentation now, Riccardo.
Thank you, Rebecca, for this nice presentation, and thank you also for participants to be here today to listen to this webinar on CBTe for adolescents. These are my disclosure, our book disclosure. And I just start to give some background about the anorexia nervosa and eating disorder in adolescents. We know as a clinician that anorexia nervosa has a profound impact on physical health and psychological functioning of adolescents. And there is a general agreement that it is very, very important to treat anorexia nervosa and the other eating disorder early and most of all effectively to avoid the long-lasting complication and impairment that we see often in adult patients with eating disorder. A particular form of family therapy, the name is Moderator therapy, or for the use cases known as family-based treatment, is the leading empirical supporting intervention for adolescents for the disorder. However, FBT has some limitation. First of all, it is not acceptable to some families and patients. And if we look at the data of the best randomized control trial, clinical trial we have that assessed the response rate of FBT in adolescents, we see that fewer than half of the patients make a full treatment response. Other problems that I and other colleagues observe clinically is that when the FBT doesn't work, it can increase in some patients the patient resistance to the treatment, because it is based on the external control. And I will come later to explain this part. The other problem that I see in some patients that are not responding to FBT is that it doesn't help to the patient to understand the psychological meanings associated with shape, weight, and control, because it is based on the externalization approach. I will describe better later when I will compare in detail the FBT with CBTe. As one of the leader of the FBT, as leader researcher on the efficacy of FBT affirmed in 2011, FBT needs to be modified to make it more acceptable and effective, or alternative treatment approaches need to be found. And we think, me, Rebecca, and other colleagues from Oxford, we think that CBT can be the most valid alternative to family-based treatment, because as I will explain you, CBT works across all the eating disorder diagnosis, and younger patients have essentially the same eating disorder psychopathology as older patients. In this webinar, I will address briefly 5 main topics. I will discuss some characteristics of eating disorder in younger patients. Second, I will give an overview of the CBT, or how we adapt the CBT for the younger patient. And I will describe the differences, but also some similarities that between CBT and family-based treatment. And I will describe rapidly the effectiveness of CBT in the study that we made, in some cohort study that we made here in Italy. And I conclude with the influence that these studies had on the health policy, especially in England, but also in other countries. Okay. If we look at the psychopathology that it is operating in the younger patient, we can conclude that young patient has the same eating disorder psychopathology of old patient. Some typical expression of eating disorder psychopathology, like the over-evaluation of shape and weight, the strict dieting, the self-induced vomiting, laxative misuse, binge eating episodes, excessive exercising, we can see these 4 expressions of eating disorder psychopathology, both in adult but also in adolescent. We also just concluded a study that it is impressed in International Journal of Eating Disorder that I made with my colleague Simona Calugi, that helped me a lot in developing the the adaptation for CBT for adolescents, we use a new statistical approach. And in this study, we clearly show that the adults and adolescents, we assessed 382 adolescents and 893 adults. The shape over evaluation, feeling fat and desiring weight loss are the most central highly connected nodes in the network in adults and adolescents. And this is in according to the theory of the CBT theory, cognitive behavioral theory of eating disorder, that support that the over-evaluation of shape and weight is the core psychopathology of eating disorder. And also there are the notes about eating behavior and the notes about body image concern, they form distinct in clusters. So this finding of this study support the use that they have adults and adolescents have a similar psychopathology, and so support the use of similar strategies and procedures to address the eating disorder psychopathology, both in adults and in adolescents with eating disorder. If we look also to the DSM-5 diagnostic categories that we have in our sample, in our clinical service, from consecutive patients from 2016 to 2018, we had 126 adults and 81 adults. You see that the DSM-5 diagnostic categories of eating disorder are present both in adults and in adolescents, with some minor differences. As you can see in the slide, adults, a larger percentage of adults have satisfied the diagnostic criteria of bulimia nervosa, and a higher percentage of adolescent patients satisfy the diagnostic criteria for atypical anorexia nervosa. However, as I want to underline that most of the other eating disorder diagnostic DSM-5 eating disorder diagnoses are present both in adolescents and in adults. However, the eating disorder in younger patients with eating disorder have some distinctive feature. For example, most adolescent patients are highly concerned about issues of control autonomy. However, this is not a problem for CBT because it is designed to enhance the patient's sense of control autonomy. And I want to underline, but I will describe this concept also later, that CBT is a very, very collaborative approach with the therapist and patient work together to overcome the eating problem. Another distinctive feature is that many adolescents are in a very egosyntonic phase of eating disorder, and so they are highly ambivalent about the treatment. However, also this is a problem addressed by the CBTe because it is designed to be engaging and to address specifically ambivalence and the egosyntonic features of the eating disorder psychopathology. Another distinctive feature is that some patients, especially the younger patients, do not report the over-evaluation of shape and weight, but just the over-evaluation of their eating per se. However, CBT developed an adaptation of the body image module to address this form of a psychopathology that is common in younger patients with eating disorder. An important this difference is that in the great majority of the case, the patient parents need to be involved in treatment. And this requires modifying the CBT, and I will describe you briefly how we involve the patient in a CBT that I remember that it was for adults, it was designed especially to be one-to-one session. Another distinctive feature is that the youngest patients require a treatment that matches their cognitive development. And we also think that this problem is easily managed in CBT, because CBT is not a complex treatment to receive by the patient. And most of the adolescents understand very well the concept, the goals, and the strategy and procedures of the CBT. An important aspect that is very important for all the patients with eating disorder, especially the underweight patient, but especially in younger patients, that the patient's physical health is of particular concern, especially in younger patients, because the organs of younger patients are not completely developed, like, for example, the bones or the brain. And so we suggest that the younger patient needs a careful assessment and monitoring, and sometimes a lower threshold for providing patient with a more intensive intervention, like, for example, hospitalization. In the second topic that I address is to give you an overview of the CBT for younger patients. We have, if you are interested in learning more, and in this month, the 23rd of April, will be published the manual of cognitive behavior for adolescent with eating disorder, that is forwarded by also Christopher Faber, and you'll find the description in detail of the manual for adolescents with eating disorder. I take the occasion to thank my colleagues, co-author Simona Calugi, that co-authored the book with me. How we develop CBT, also the idea of adapting CBT for eating disorder, for younger patients with eating disorder. I had the occasion to meet my mentor, but I can say also my good friend, Christopher Faber, many years ago. And I started to discuss with him the possibility to adapt the CBT for intensive level of care. This picture is the Villa Garda Hospital, that is one of the first inpatient unit of Italy, completely dedicated for eating disorder. And we started to discuss the possibility to adapt also CBT for intensive level of care. And I received a grant to do a randomized control trial to compare two forms of CBT in inpatient treatment, the focus form and the broad form. And during the supervision, I was very lucky to have for at least 5 years, Chris Faber, that came very often in my unit to give a supervision to this trial. And during the supervision, we started to think together that maybe this approach can be also adapted to adolescents in outpatient setting, because I have a long clinical experience, because I started to work with eating disorder in 1984, that many patients, also adolescent patients with eating disorder, can be actively engaged in the treatment of eating disorder, and they do not need an external control, for example, like family-based treatment. So I started to discuss this hypothesis with Chris Faber, and we discussed together how to make some adaptation to the CBT for adolescents, and together, and we develop this new treatment for younger patients with eating disorder. And this led also to make some cohort study that I will present later. I think everybody knows that the CBT, the theory behind behind CBT CBT has a transdiagnostic perspective on the eating disorder psychopathology, rather than considering the eating disorder as distinctive disorder. In CBT, we are focused more in addressing the eating disorder psychopathology that is operating in the single patient. And this has, both theoretical and treatment implication. The theoretical implication are that the eating disorder psychopathology is likely to be maintained by a common set of processes, whatever the DSM eating disorder diagnosis. And we develop a personal formulation with the patient, and this helps us to individualize the treatment and to address just the psychopathology that is operating in the patient, not the DSM-5 diagnosis. And the treatment implication are that the treatment should be able to address the eating disorder psychopathology independently by the DSM eating disorder diagnosis. The main points of a young CBT for younger patient is that it uses similar strategies and procedures as the adult form of CBT. However, there are three main differences. We give a lot of effort to engage the patient from the very outset of the treatment, because as I discussed with you before, most of the patients are very ambivalent, and they are in a very egosyntonic phase of their eating disorder. We also found in the core study that we made that in many patients the treatment can be shorter, because when we are able to engage actively the patient in the treatment, the change occurs more rapidly. And in most patients, underweight patients, for example, we can conclude the treatment in 30 sessions rather than the recommended 40 sessions for adult patients. And also parents are always involved in the treatment. And I remember you that on the contrary, the significant other of adult patients are involved only with the agreement of the patient, and if the patient, both the patient and the therapist thinks that they can help the treatment. The CBT for younger patients has four main goals. The first is to engage the patient in the treatment and to involve, I underline, actively in the process of change. This is a very specific characteristics of a CBT, involving actively the patient in the treatment. The second is to remove the eating disorder psychopathology. When I speak about the eating disorder psychopathology, I mean the expression of eating disorder, typical expression of eating disorder psychopathology, like dietary restraint, for example, low weight, extreme weight control behaviors, the preoccupation of shape and weight. But it is also important, according to the CBT perspective, to correct the mechanisms that are maintaining the eating disorder psychopathology. For example, it is not enough to correct the body weight, but also the mechanisms that are maintaining the body weight. So the strict dieting, but especially the over-evaluation of shape and weight. And for example, it is not enough to remove the binge eating, but also the mechanisms that are maintaining binge eating, for example, the strict dieting or the events and moods that influence eating. The last aspect, the last goal of the CBT that is very specific of CBT is to ensure lasting change, to have a patient to develop specific skills to prevent the relapse. I think that a specific aspect of CBT that make the CBT for younger patients very different from other approaches that are used in adolescent patients with eating disorder that we never use and never adopt prescriptive or coercive procedures. So what does it mean? We never ask a patient to do things that we do not agree to do. The key strategy of CBTe is to collaboratively create a personal formulation on the main processes maintaining the patient's individual psychopathology, because this process will become the target of a treatment. We educate in a very individualized manner the patient about this process, developing collaboratively the personal formulation, and we actively involve the patient in the decision to address them. If the patient do not reach the conclusion that they have a problem to address, for example, they don't reach the conclusion that low weight is a problem to address, the treatment cannot start or must be suspended. But this, as I will describe in the study we made on the effectiveness of CBT for younger patients, is not a common occurrence. When we address the eating disorder psychopathology with a flexible and personalized set of sequential cognitive behavior strategies and procedures integrated with progressive patient education. We use many cognitive strategies and behavioral strategies. However, we try to achieve cognitive change, encouraging the patient to observe using what we call the real-time self-monitoring, how the processes in their personal formulation operate in their real life. Then we ask patients to try to make gradual behavioral changes and analyze their effects and implication on their way of thinking. In the later stage of the CBTe, the treatment focus on helping the patient recognize the early warning sign of eating disorder, what we call mindset reactivation, and to the center it quickly with the goal to avoid a relapse. This is the treatment duration. We have 2 pre-treatment assessments. We privilege to see alone the patient because the goal is to assess the psychopathology present, the severity of the eating disorder. But for us, it is important also to understand the perspective of the eating problem, the perspective of the young patient of the eating problem, and also to share from the beginning that we operate for the patient, not for the parents. And so we start to engage the patient in a collaborative way just from the beginning of the assessment, some the assessment part of the session, sorry. And we have the occasion also to give an explanation of the eating problem and to share a psychological explanation of the eating disorder that is very appreciated by the patient. And it is also an occasion to describe how the treatment works and the structures and the goal of the treatment, and we ask the patient to be involved in the decision to start the treatment. We have also the treatment then include from 30 to 40, 50 minutes individual session in patient with BMI between the 3rd and the 25th percentiles, while we maintain the classical duration of 20 weeks and 20 sessions in young patients that are not underweight. And after, we have 3 post-treatment review sessions after the completion of the treatment, after 4, 12, and 20 weeks. And we decide also with Chris Fable to include more post-review, more frequent post-review session, because in some adolescent patients we have to, if there are some early signs of relapse, we can intervene rapidly. I remember you that in the standard CBT for adults with eating disorder, there is just one post-review session after 20 weeks. I have no time to go in detail because we need a couple of days of workshop to describe all the procedures and strategies of CBT. However, I just synthesize the main core procedures of CBTe, the focus form of CBTe. I remember you that when we say the focus form of CBT, we refer to the standard treatment, and is the treatment that addresses the eating disorder psychopathology of the patient. These are the 8 procedures. One of the most important, especially in adolescents, is to engage the patient. We help the patient to identify and analyze the relevant phenomena using real-time recording, and also to help patients to establish a stable pattern of regular eating. This is common in the first phase of the treatment, and it is common for both for not underweight but also underweight patients. And a specific characteristic of CBT, both for adults but also for adolescents, is that in the first part of the treatment, the focus is not weight regain, but to help the patient to understand that underweight is a problem and to choose to regain weight. When they choose to regain weight, we do so. We also address another core procedures is to help the patient identify and address shape and weight concern, what we call the body image module, or the over-evaluation of shape and weight. Help the patient recognizing the diet is a problem and to address it is another typical ego-symptomic characteristic of the eating disorder psychopathology, and also help the patient to deal effectively with difficult events and moods, and at the end to help the patient to identify setbacks and respond promptly to them. We have also 4 modules that we use, and this is the CBT form of the CBT broad version of CBTe. We have 4 modules that address what we call in CBT terminology the external maintaining mechanism of eating disorder. These are clinical perfectionism, core low self-esteem, interpersonal difficulties, and mood intolerance. We address this one, is very in rare case 2 of these external maintaining mechanisms only if 3 conditions are satisfied. These external maintaining mechanisms are pronounced, they appear to be maintaining the eating disorder and seem likely to interfere with a response to treatment. If all these 3 conditions are satisfied, we include 1 or in rare case 2 external module. This is the CBT map for younger underweight patients. There are two maximum 3 assessment and preparation sessions. After we have I use the step here, but we use the step to explain the step that we use to address weight regain. Step 1 is similar to the stage 1 of a standard CBT. We call starting well and decided to change. And these are the procedures: engaging the patient, and establishing real-time self-monitoring, establishing collaborative in-session weighing, providing education, jointly creating the personal formulation, introducing a pattern of regular eating, and we dedicate many sessions to think about addressing weight regain, and we involve the patient, especially after the regular eating. Usually, in the step 1 include twice a week session, and it lasts about 4 weeks. But in some patients, we can reduce the step 1 in 3 weeks, and in rare case, more of 5 or 6 weeks, but it's very rare. In most of the cases, we conclude step 1 in 4 weeks. If a patient decides to address weight regain, we go in step 2. Otherwise, we stop the treatment and we refer the patient to other type of treatment. And step 2 has the focus CBT modules. There is the underweight and undereating modules, the body image, the dietary restraint, the events and mood changes modules, and setbacks and mindset modules. Or we have the 4 modules for the broad CBT. Every 4 weeks in underweight patient, we dedicate a part of a session to do a review. And in this review session, we conduct a joint review of the progress. We identify emerging barriers to change. We review the formulation, and we decide to use or not the broad form of CBT. And we plan the rest of the treatment. The step 3 is ending the treatment, ending well. We dedicate 3 or 4 sessions every 4 weeks. I forget that we continue to deliver twice a week session until the body weight of a patient regain in a regular way. We have 3 or 4 sessions every 2 weeks in step 3. And the goal is ensuring that the progress is maintaining and minimizing the risk of relapse. And after, we have a post-review session, as I described before. We involve the parents, as I described you before. We dedicate 1 15-minute session only with parents. And in this session, we educate the parents on the eating disorder and their role in the treatment. We explain the cognitive behavioral theory on how eating disorder are maintaining. We instill hope in the parents, and also we explain the nature, the style of the practicalities of the treatment, and also the role of the parents, that is like helper, not controller, not helper. We also dedicate time to create an optimal family environment. If some parents are dieting, we address this, how to keep junk food in the house, the comment about patient eating during the meals, we create an environment that does not encourage concern about shape and weight, how to create a warm and serene home environment, and instilling hope. We also try to address if we find some barriers to change, like logistical, cultural, disagreement or the nature of a treatment, or disagreement between the parents about the need of a treatment, or if some parents has clinical depression or other mental disorder, we try to address also these barriers to change. During the course of a treatment, we are very flexible in involving the parents. However, usually we include 8 to 10, 50 to 20 minutes joint session with the patient and parents, and this joint session is scheduled at the end of the individual session with the young patient. And the goal is to inform the parents about what is happening and the patient progress, and to discuss, however, with the patient prior agreement, how they might help the patient make change. This is very specific of CBT. First of all, we discuss with a younger patient, I think, what do you think that if we involve your parents to help you in regular eating or addressing the need to use some specific strategy to help you to eat? If a patient agree, we discuss with the patient the type of help, and after we involve the parents in asking if they are available to help the patient. Now I want to discuss the difference and similarity between CBT and FBT. I have to thank my colleague Sarah Riccardo from the Children's Hospital of Minneapolis, Simona Kalugin, and also Daniel Lagrange, that we publish a paper on Journal of Eating Disorder. Is open access, so you can see in more detail we describe in detail the difference between the two types of treatment, FBT and CBT. The first difference is, a radical difference, is the conceptualization of eating disorder. You know that according to FBT, the problems belong to the entire family and the illness is separated from the patient. The patient has an anorexia nervosa, okay? In CBTe, we never externalize, we never separate the illness from the patient, and we say that the problems belong to the individual. And the goal is to help the patient to reach the conclusion that the control of shape, weight, and eating is a dysfunctional way to pursue a good self-evaluation. And it is also associated with physical, psychological, but especially in adolescent, interpersonal impairment. And the goal is to share with the patient that the treatment has the main goal to help that this system of self-evaluation is dysfunctional and to find with the treatment a more functional system of self-evaluation. And this clearly changed the involvement of the patient, that in FBT is not actively involved, while in CBT is actively involved. And the parents' involvement in FBT is vitally important. In CBT is useful but not essential. Also, the treatment team is different. In FBT is multidisciplinary. In CBT there is a single therapist, or when the patient is severely underweight, with the help, there is a dietitian, but the dietitian also can help, but should have a training in CBT. And this session are 80 family sessions, 20 sessions in CBTe for not underweight, 30 in underweight. But also I want to remark also that FBT include very often also a consulting team like pediatrician and nurses. However, there are also some similarities between FBT and CBT. Both address the maintaining mechanism of eating disorder psychopathology, not the potential causes. A major focus of both treatment is to help the adolescent patient to normalize the body weight. And both FBT and CBT, although using different procedures, include regular weighing of the patient within each session. And there are also potential common mechanisms of action of the two treatments. For example, Hildebrand underlined that exposure and habituation to feel food and its consumption can be a mechanism of the two treatments. And also, in some way, the two treatments produce an indirect reduction of the order evaluation of shape and weight, CBT enhancing the importance of other domains of life, and FBT working toward increase the personal autonomy for adolescents. It is clear that both manage the comorbid psychiatric diagnosis or hospitalize the patient in case of the patient presents some medical instability. Briefly, because I want to leave time for the discussion, I see there are many questions. I briefly show you the data on the effectiveness of CBT. This was the first study that we made in the outpatient study on 46 patients with anorexia nervosa, no concomitant treatment, just CBT. You see an increase, a normalize of body BMI percentiles, and interestingly, after the end of a treatment at 60 weeks of follow-up, there was an increase of body weight. And this increase of body weight was associated with a normalization of the eating disorder psychopathology. However, there was 35% of the patients that did not conclude the treatment, and 50% of these patients were hospitalized in intensive CBTe. This is an interesting study that we compare the CBT for adolescents with adults, and we saw that CBT for underweight for adolescents seems to work better than adults. You see 63% of adolescents versus 36.5% of adults normalize the body weight. And interestingly, the time required by adolescents to restore body weight was about 15 weeks less than the adults. This is one of a few studies that have been published on not underweight eating disorder adolescent patient. This study involved 68 adolescent patients with a BMI, a normal body weight. And you see that the response rate was good. The intention to treat was more than 60%, in completers 80%, and we had a 25% dropout. This is the last study that I want to present you. It is interesting because it was a real-world setting. The CBT for adolescents was delivered by 3 psychologists that received a training on the web training of Oxford and the specific training to use the CBT for adolescents. They included, they treated 49 consecutive patients, 15 years of age, and with a mean duration of eating disorder at about 1 year. And you see 96% of the patients agree to address the treatment because the step 1, that is not addressing the weight regain, is not a threat for the patient. So most of adolescents decide to start the treatment. The completers were 71%, and as you can see, there was this graph includes all the patients. There was an improvement of BMI centiles and a reduction of eating disorder psychopathology and also of the impairment associated with the eating disorder. We didn't find any baseline predictor of dropouts. The last part of I'm going to conclude, this data and this study had some influence on the health policy. This was an important document in July 2015 on the National Health System from England. The focus was to assess and waiting time standard for children or young people with eating disorder, that in the recommendation affirmed that there is emerging evidence to suggest that a specifically adapted form of CBT may be effective in anorexia nervosa in young people. And we are very happy that CBT now was in May 2017 recommended as an alternative, a second-line treatment, but as an alternative of family treatment, both for bulimia nervosa and anorexia nervosa, and also for binge eating disorder if guided self-help is not effective. If you want to have more detail with my colleague Rebecca Murphy, that is moderating me now, and other colleagues, we just developed the CBTe website where you can find many information about CBT in general, but also CBT for adolescents. In conclusion, I can say that CBT is suitable for adolescent patients with anorexia nervosa, and we have another promising treatment for adolescents. And this opens, in my opinion, the opportunity to compare family-based treatment with CBT in a randomized controlled trial. And we are, as a clinician, but also as a clinical researcher, I am interested in to assess some key variables: the relative acceptability of the two treatments, their effectiveness and the ability to produce enduring change, the relative cost and cost effectiveness, but most of all, because this is a very important clinical question, what are the moderators of the treatment response? So, because if we know which type of treatment works better for this patient or the other patient, we can match the adolescent to the patient or to CBT or FDT. Thank you for listening to me, and now we have time for 10 minutes or more for question and answer.
Thank you very much, Riccardo, for a very informative presentation. I'm just going to have a look at the questions now. There are some questions asking for the slides, and as I understand it, if you're happy, Riccardo, we can actually pass these on so they can be shared with people on the AED website. Are you happy for that, Riccardo?
Yeah, I'm very happy to share because, you know, one of the goals of CBT, the founder of CBT, Christopher Faber, is the dissemination of knowledge about CBT. So I'm very happy to continue to try to disseminate, to give also all the slides, and also if you have some questions to go in the CBT website, that you can submit any question, and we'll be very happy to help you.
That's a good idea. I'm aware that we might not get through all the questions today, so as long as the AED lets us keep these, Riccardo, we could perhaps try and answer some of them and put it on the CBTe.co website somewhere.
Yeah, I think it is a good idea.
Yeah.
I agree completely.
Great. So one of the questions was also about the online training, and I can just answer that quickly to start with. If you go to CBTe.co website and you look at the information for professionals, you can see that there is a description of some free online training that we offer in CBTe. Once you've completed the main course, you can request access to supplementary modules, and that includes a module which Riccardo has created on working with adolescents using CBTe. I think if you do that training and in addition get the book that Riccardo and Simona have written on CBTe with adolescents, that will give you a good grounding in training in CBTe for adolescents. Would you agree, Riccardo?
Yeah, completely. And you know, I think it is a good occasion, and we have many clinicians all around the world that attended to the web training. And I think it is a very good occasion to learn better how to deliver CBT, because there are a lot of clinical examples, role playing, and a lot of material that if you integrate with the two manuals, but now we have two manuals, one for the adult and the new one for the adolescent, you can deliver well this type of treatment. And we really encourage that you attend to the web training. That is completely free of charge. I have to underline also this.
Great, thank you very much, Riccardo. And another question that we had was, is there a book or some reading that you would recommend if somebody's working with a 12-year-old girl who's been hospitalized for restrictive anorexia nervosa for the patient to read?
Yeah, I have not much experience about this, because most of the patients we treat are from the age of 13. In outpatient setting, we included some patients of 12 years old. This depends by the cognitive development of the patient, you know, because this is a cognitive behavioral therapy. I don't have experience in patients of 12 years old hospitalized, because in my unit I start to hospitalize from the age of 13. However, there are some paper, and also I wrote a book on the adapting CBT on inpatient treatment for adolescent. And in the new book, there is a chapter completely dedicated to the adaptation of CBT for adolescents in intensive level of care. So you can refer to this chapter and also to make some other adaptation for the age of the patient.
Great.
What we found, however, we didn't find any predictor of change. So when we were in the last study that I show you, and we were very surprised about this, because we thought that CBT works better with older adolescents when the cognitive process are more evident. But indeed, but on the contrary, we found similar rate of response also in the younger patient, 13 and some 12 years old patients. So this is an interesting, it is clear that we have to reply this study, but it was an interesting finding.
Great, thank you very much. And I see there are some other questions related to that about the age limit for CBTe, and it sounds like in your work you're seeing adolescents from age 13 upwards. Is that right?
Yeah.
And there are a few questions around what strategies you might use when a young person is very ambivalent about treatment. I'm aware we're also running out of time. We've got a few more minutes, so if you could answer that one briefly, Riccardo, and anyone else, we'll try and write a document with the responses. We'll give it to AED and we'll put it on cbte.co as well. Yeah,
is a very important question, and it is a question that need a description of the core procedures of CBT of engaging the patient. However, we use some specific procedures. First of all, we try to see the patient alone from the beginning. We try to share with the patient that we operate with them. And also, we are very curious to understand with the patient the positive meaning that they have in the controlling about weight and shape. And we help the patient to discuss if this is just a personal choice or is becoming a problem. And I see that two things that are very, very helpful in engaging the patient. The first is to analyze the interpersonal impairment associated with eating disorder. Adolescent patient doesn't care about the physical and also the psychological impairment, but they are very, the interpersonal impairment is very ego dystonic. The second, we try to, with personal formulation, to educate the patient and to give a psychological meaning to the disorder. So, as I told in the presentation, we try to share with the patient that the goal of controlling body weight and shape was not, according to this psychological meaning, a mistake, because the goal is to improve the self-evaluation through the control of body weight and shape. But this is dysfunctional. It is dysfunctional because it creates damage and you never reach a good system of self-evaluation. So we try to instill the idea that with the treatment you can find a better way to reach a stable and more articulated way of self-evaluation. And I saw in my experience that if you share this psychological meaning of control of body weight or shape, this attracts a lot of the eating disorder, that they are not labeled as I am an anorexic, you have a psychiatric disorder, but there is a meaning behind the behavior. And this helps, and also another aspect that engage the patient is there is not from the beginning a pressure to weight regain, but to help the patient to understand better how the eating disorder function and to decide to address or not weight regain and all the other expression of the eating disorder. Great. Thank you very much, Riccardo. And thank you for a fantastic presentation. And thank everyone for coming and your questions. We will try our best. I'll ask Riccardo to kindly try and answer them
and we'll post it on our CBTe.co website and give it to AED, hopefully, if Riccardo's willing to. And you can find out about this and other upcoming webinars on the aedweb.org website by clicking on the events tab. Thank you very much for participating, everyone, and enjoy the rest of your day.
Thank you very much, Rebecca, and thank you for everybody.